usually a delay in diagnosis, in the sense that many people sort of suffer in silence or sort of normalize it, or for various reasons, which I might touch on later on, there is a bit of delay in diagnosis. So, and when there's a delay in diagnosis where you don't know what you're dealing with, it can have a larger impact on you as well. Endometriosis at some point used to be seen as a white woman's disease, used to be seen as something that it doesn't happen in the Black people. But we've realized that that's not necessarily true. It does happen in anybody, irrespective of your race or what you look like. But it's just that in the minority groups, it's underdiagnosed for a few reasons that I will mention as well. We do know that in the minority group, pain is usually normalized, and it's just like pain is something you deal with. So what exactly is endometriosis? And I know it sounds like a big term, but to explain it in simple terms, it's basically when the lining of your womb, when tissue that is similar to the lining of your womb, when it's present outside the womb. For people that are a bit involved in cooking, if you think about the lining of the stomach or like tripe or, intestine, when you're cooking, there is a lining inside. Most organs have a lining. And when it's supposed to be restricted to that organ, but when it's present in other places that you don't need it to be, that's when it is endometriosis. So because it is tissue that is like the lining of your womb, it sort of responds to normal hormonal changes. And this lining of the womb is what we usually bleed monthly. This is what we usually have as a period every month. So every month, due to hormone changes, when you're having a period, when this tissue is present in other parts of the body, it can cause inflammation and it can cause a lot of pain as well. And there are common places where it can happen, and I've shown that in the picture that I've put next to it here. It's very common in the pelvic area, that's in the lower tummy area. And I've put examples of, I don't know if you can see my cursor, but this is something like when this tissue clusters together, when it's present in the ovaries here, or in the tubes on the outer part of the womb here. It can be present anywhere, even just scattered around the intestines, around the bladder. In very rare cases, have been reported where it's present in like even the hands, and it responds to cyclical changes. So when you're having a period, some people have reported that they do have like discoloration, like bluish thing in their hand when they're having their period, which is painful as well. So it can be present in any part of the body, but it's very common around the womb area. It's important to know that it's not an infection, it's not cancer, it's not related to what somebody did, like, oh, it's because of a certain lifestyle you did. It's not like that. It's just the cause is unknown. We don't really know what causes it. There are a few ideas, but we don't know the main cause. So it's not what anybody did, it's just something that can happen. If we think about how it can affect people, it can cause, I think, most common symptom is pain. Pain is something that women will always talk about. So very severe menstrual cramps or menstrual pain, like women will say it. Sometimes the pain can be before the periods. Sex can become painful. There can be this persistent pain in the tummy, persistent pelvic pain. Heavy periods is another very common symptom. And obviously, if a woman is bleeding and constantly in pain, it can cause tiredness, fatigue. And when you're having to deal with all these things, you're just constantly tired, and the mental impact of it can also make you tired. If these tissues are present in around your bowels, it can also cause painful bowel movements, especially during your periods, or pain when passing urine during the periods. And it can also cause infertility as well. That being said, those are the symptoms that you can sort of put, that you can list. But in terms of the functional impact of it, obviously, if there's heavy pain over and over, there might be repeated hospital admissions due to pain. And I'm sure a few people growing up will know if one person or the other that probably usually misses school or is at home, has to ring in sick from work or work just because they're in a lot of pain. And so our next name, we just say, oh, that person has menstrual pain. Like, oh, our menstrual pain is always bad. But Is that normal? If pain is actually stopping you from living your life, then that's not normal. That needs to be looked into. Obviously, if sex is becoming painful in a relationship, it can have its own effect, causing strain in the relationship, and that can even overall affect the mental health, causing anxiety or some form of depression or just mental health troubles in general. I've put this slide there and I've labeled it a strong Black woman. And that's because I mentioned earlier that, in the Black and the minority population generally, it's underdiagnosed. And I think one major common reason is because we have normalized a lot of the symptoms. Pastor Stella spoke earlier and said I will be sharing this as part of my, I'll be giving a professional opinion and I'd also be sharing my personal story. So as a young girl myself, I really struggled with these symptoms. I would have very terrible menstrual pain, like we used to call it then. And I did have heavy, heavy periods. I would really struggle during exams. I would have to, take some time out to actually go and have a change, go and take a sanitary towel during an exam where you don't have enough time. I have to go and do, otherwise I'm going to flood the whole time. And if I'm having my period during an exam as well, that means I'm not going to be optimal during that exam. I know I just have to hope not to fail the exam and not, be at my best. I would plan my life around my period. I would, if I had a travel planned or I had a trip planned, I would have to cancel it because I can't deal with it during my period. And it was very heavy on me. It was something that was really impacting my day to day. But for some reason, everybody was just like, oh, Ife has really bad periods. And we just dealt with it. It was just like, oh, try this thing, try this thing. And I remember back then I would buy the really strongest pain relief because I would be in so much pain. I would be nearly passing out. And I would be buying all this, really strong pain relief just to get me through the day and help me manage. But then obviously, as I got into medical school, I realized that, okay, there is help and support available. And I did seek help, and I can say that my life is transformed, and I don't struggle like I did back then. So it is important to know that, the main strength that we should have as a Black woman is not suffering in silence, is actually speaking up and seeking help when something doesn't feel right. We should remember that there is a little bit of pain bias in healthcare as well, where Black women's pain is sort of minimized, it's sort of undermined because we're sort of seen to be able to deal with pain better. I know that some cultures and society expectations also make it difficult for women to talk about their periods, and in that way, it's difficult to share experiences and know that there is actually a problem. So, um, because it was also thought to be a white woman's disease in the past, and we do know that in Black women, fibroids are common, and the symptoms are very similar. So there is a very high chance that all the symptoms are put down to fibroid. But we do know that three things can exist at the same time. So you can have fibroid and also have endometriosis as well. So it's just something to think about. I've put here just the delayed diagnosis, the things that can be responsible for it. And I've put the strong Black woman bias, which is just normalizing everything and dealing with it and keeping quiet. And sometimes symptoms are dismissed. Sometimes, you had a scan done, which is normal, but a normal scan doesn't exclude it. It can take a few years before some people are referred. And obviously, we know the current delays that we have in the NHS at the moment. Even after you are referred, it can take a while before you are seen. I've put a slide here that talks about how to prepare for your GP appointment, which I think is very important, and helps you to make maximum use of your opportunity with your GP. Don't forget that your GP has a very short time to spend with you. It's just 10 to 15 minutes that they have to listen to you, examine you, do all your tests, write your notes. So it's quite a short time, but you need to be very focused to make sure that you pass your message across properly. You can check the practice website. You can book with a female doctor if that makes you feel better. You can, whatever makes you feel a bit better about it, write your thoughts out. Make sure you write it down so that you don't forget. And make sure that before you go, you ask about what's the next steps. What do I need to do next? Your GP can recommend a few things for you, like blood to check. Obviously, if you have been bleeding a lot, your blood levels can be a bit low. They might recommend like an ultrasound scan, some pain relief. But I wouldn't go into this too much because Dr. Ajayi will be focusing on this. I just want us to know that endometriosis is very common. It is treatable, and there is support available. Um, it's not a white woman's disease. It is very common in the Black woman, and it is common generally. Any pain that is affecting your day to day, or if your periods are heavy to the point where you cannot function around it, then it's not normal. You need to see someone. Before you go and see your GP, prepare for the appointment, write it down, make sure that all your concerns are written out and prepared such that your time is used appropriately. And don't you suffer in silence. Strength is not suffering quietly. Strength is actually speaking out and getting help. I'm going to stop here and then let Dr. Ajayi take over the rest for me. Thank you.
Okay, thank you very much, Ife. That was very straight to the point. Please, if there is anyone listening in right now, and you're thinking, that sounds like me, just like Ife has said, don't sit there and suffer in silence. Don't say, well, my mom had it. My mom had serious menstrual pain. My aunties have it. Please go and get yourself checked. It's so important. Okay, please. That's the reason why we're doing this, so that you do not suffer in silence. Look at all the things that can happen. And we don't want these things to happen. And that's why we're doing what we're doing now. So I'm going to, move you on to Dr. Ajayi. But before I do that, I'm just going to, tell you a bit about him. So Dr. Ajayi is a consultant obstetrician and gynecologist. He works in the NHS. He is a medical teacher, trainer, and obviously an advocate for women's health. So we are in a good place with a good man, and he's going to, do the best that he can, just to explain this to us as well. Now, remember, if I looked at it from the GP aspect and also, from personal experience, so Dr. Ajayi is going to look at it, as a gynecologist, he's going to, do it that way. So over to you, sir, if you please want to unmute yourself.
Okay, thank you, Pastola. Thank you. Phil. I think you've made everything easy for me in that sense, with the excellent look at it from the GP perspective. And I'm not going to repeat some of the things you've said. Let me just share my screen. Just bear with me.
Please, while Dr. Ajayi is sorting out his screen, if you have any questions, I've got a few here so that by the time Dr. Ajayi finishes, we can take these questions, whether they're general questions or they're questions that relate to the topic for today, which is endometriosis. Please feel free to send them in to myself. Please don't put it on if you're comfortable putting it, for everyone to read, that's fine. But if you just want to send it directly to me, then please feel free to do so that we can take those questions at the end, whether they're general health, women's health questions, or they're just, questions that lead to endometriosis. Thank you very
showing
much.
now?
Yes, it is.
Okay. Thank you very much. Sorry about that. So, like I said, I'm not going to go to what Ife has already covered. So I'm just going to go straight to, okay, let me just show you a picture of how endometriosis can be like. So I don't know if you can see my cursor. So this is a picture we see on when we do what we call laparoscopy. That's a procedure to check, to investigate endometriosis. And this is the back of the uterus. This is the back of the womb. And you can see the right ovary there. You can see how big it is. This is a cyst in the right ovary. You can see all the adhesion, all the scarring, and that Ife mentioned as well. So I'm just gonna next slide. Okay, she's talked through about these symptoms, and just to mention about the in terms of the what causes endometriosis. Actually, we don't really know. And some of the factors are that of something they call about retrograde menstruation, in which instead of the blood coming through, and then some of the blood going inside, and then getting deposited on the ovary, the bowels, like Ife mentioned. Also, we know about something about the genetics, and also something to do with our immune system. So I won't really go too much into that. And also, there's something about family history. If it runs in some particular families as well. Okay. Impact on daily life. I think if I mentioned, I will just run through this. Chronic pain, fatigue, emotional and mental health challenges, impact on relationship and work, potential fertility issue is linked. Endometriosis is very, very strongly linked with struggling to conceive, infertility. So in terms of diagnosis, so how do we, so let's say if I see a patient and then she refers to me, I'm in the secondary care, I'm in the hospital, and then of course I'll have to go through the medical history again and then check the symptoms. So we might need to do some examination, check the abdomen and pelvic examination, just so I have an idea of any abnormality. And then we will recommend some imaging. So we start with a pelvic ultrasound scan, okay, just to check on the womb and the ovaries, and just to check the pelvic area, make sure everything is fine. At times, also we might recommend MRI. That's a more specialized scan of the pelvis as well, just checking the womb, the fallopian tubes, and the ovaries as well. And most times we might need to do a laparoscopy, which is a small procedure or a surgical procedure that we do in theater to have a look inside the pelvis. Okay. And at times we might have to do this to actually find out whether there's endometriosis or not, because at times if it's a small endometriosis or small spot, you might not actually see it on ultrasound scan. So at times you might just need to go in there with the camera to have a look. So that's how we make a diagnosis of endometriosis. And I think if I mentioned the fact that at times it takes a long time for some women to be diagnosed of endometriosis, because there's a bit of overlap with other conditions like if someone has got fibroids, and also because at times the GP wanted to try some things first before the referral, and some of the women at times they feel they're not being listened to. So I think that is why we doing this health talk is very, very important. That when you go to your GP, be concise, know exactly your symptoms, have a diary, tell it the way it is. And if you're not happy with what has been said, you can always ask for a second opinion from another GP. And then, so just make sure your voice is heard. So in terms of the treatment options, so these are the kind of generalized, this is an overview of the treatment options we have for endometriosis. We need to look at in terms of pain relief. We can start from the less stronger ones to very stronger ones. Your normal non-steroidal anti-inflammatory, paracetamol, ibuprofen can help. Also, we can use stronger ones like things like naproxen, tramadol. So it is a wide variety in terms of how bad the pain is. Okay, and also we tend to use a hormonal treatment as well. Like if I mentioned, these are endometrial tissue that are then scattered outside of the womb. That is what endometriosis is. So if you can find a way to limit the response of hormones to this tissue, to cut off the supply of hormones to them, then hopefully that would then that will help with the symptoms. And also, we might need to do surgery for some women. That will be the recommendation: surgery to remove the endometrial tissue wherever they are. So we normally want to do laparoscopic excisions. That is when we do a keyhole surgery to remove those endometrial tissue wherever they are. If they are inside the ovaries or on the ovary, we try to remove it. If they're on the fallopian tube, we try to remove it. If they are on the bowels, we try to remove it. Wherever they are, we try to remove it as safely as possible. And also, if there's underlying infertility in which based on the scarring and all the damage the endometriosis might have caused, then some of these women might also require fertility treatment, and we do work hand in hand with the IVF centers and fertility centers to make sure that we optimize care for our patient. And also, we should not forget the mental and the psychological side of things in terms of providing supportive care, in terms of counseling, and some women might even need physiotherapy as well. We should also recognize that if somebody has got moderate to severe endometriosis, they should be managed in Center of Excellence, what we call the Endometriosis Center, which this are very specialized units dealing with this kind of cases, in which there's involvement of the gynecologists who are experts in managing endometriosis. We have our colleagues in dealing with the bowels. We have our colleagues, our nursing team as well. So all working together to make sure that we optimize care for our patient. So talking more details in terms of the hormonal treatment, this is when we use hormonal medication. So the aim of this is to suppress ovulation, that is to prevent release of eggs, and then to stop the menstrual flow. So because of the impacts it has on the hormones, particularly estrogen and progesterone. So when we use these tablets, they will reduce stimulation of the endometrial deposits. Like we mentioned before, we know that this tissue are outside where they should be. So there's a way you can stop them by using hormone tablets or injection, hormonal methods. So it will help reduce the symptoms. The commonest one that we use is the combined oral contraceptive pill, the same one we use for birth control. We always check that there's no contraindication, no history of blood clots, and make sure that it's safe to be used. So we can try with this. And at times we do try, we can try giving it the normal way in which you have a break. You use it for 21 days, have a break for 7 days. Or at times we can use it what we call back-to-back, in which we use it without a break, just to stop the periods and see whether that will make a difference. Also, we can recommend progesterone only pill. That's the one that just has the progesterone. So as a tablet, this can also help, or we can use it as a coil as well, the Mirena coil. And also we have some injections called the GnRH analogs. Don't worry about the big names. These are just injections to stop the periods. So it stops the hormone flow from the ovaries, and then as such, the period stops, and also it will have effect on where the endometrial cells are, and then it then stops their activity. The downside to these injections that we don't like to use it for more than 6 months because of the effect. They cause a medical menopause, so the patient can develop symptoms very similar to menopause, like hot sweats, night sweats. And then at times we do an effect on the bones. It can cause a thinning of the bones if you use more, if it's used more than 6 months. And then that would then mean that we then need to give another tablet to like help with that side effect. So that at times this makes it a bit unattractive for some of our patients, in which they don't want the side effect. Okay, so talking about the surgical management. So I mean, who are those patients that who do we offer surgery to? This is when medical management has failed. We can't use it for whatever reason, or if a patient has a severe disease, if there's severe disease in which there's endometrial deposit everywhere, maybe on the bowel, on the bladder, on the ureter. Ureter, that's a pipe that links the kidney down to the bladder. Or if there's infertility. So these endometrial cells, because of the inflammation and the scarring, they could have caused damage to the fallopian tube, in which that patient might not be able to get pregnant. And also, if you have a large endometrioma, endometrioma means a big cyst in the ovary, which is caused by endometriosis. If you imagine every month with the bleeding inside the ovaries over a period of time, this bleeding accumulates and then form a cyst. So that is what endometrioma is. And then, so for those patients that we earmark for surgery, we normally like to do a laparoscopy. That's what we call a keyhole surgery, to go in to remove this endometrial tissue wherever they may be safely. If there's a cyst on the ovary, we try to remove it as well. If there's any adhesion, which is scar tissue, we try to divide it as well, and try and do as much as we can for our patients. Particularly for those that still want to get pregnant, or for those that have issues getting pregnant. And let's say pregnancy is not an issue or it's not desired. For some patients, they actually need to have a hysterectomy, which removal of the ovaries, if they don't wish pregnancy or family is complete. So those are the kind of surgical management that we offer. And like I said, we try to do this by keyhole procedure, but we know at times it might be difficult doing it keyhole, in which it might have to be open procedure. And some centers of excellence, like I mentioned about the endometriosis center, they're actually using robotic surgery to do these surgeries these days as well. This is just some pictures that I just wanted to show to us. So this is a normal looking pelvis. You can see I don't know whether you see my cursor there. So that's the back of the womb, and that's the so that's the fallopian tube on that side, on the left side, on the right side, and this is the ovary, left ovary, and you can see it's very, very clean pelvis. This is a normal looking one. Compared to this one, you can see this black spots. That's endometriosis, and also on this side as well. So, and then there's a bit of scarring there. If you look at this other picture as well. So this is how endometriosis looks like when you are looking looking down into the pelvis. What other things can we do to help our patients? Lifestyle and supportive measure. We can recommend regular exercise, eat therapy just to help with the pain. Physiotherapy can be also beneficial, and then psychological support for chronic pain. One of the difficult thing managing this patient, if they got chronic pain, can be very, very difficult. And at times we do refer them to the chronic pain team just for support in regards to their pain. And also dietary changes. Some reports said in terms of some diet or some food causes aggravation of the pain. So one can look at those areas as well to check what can be changed from the dietary point of view. There are a lot of support group out there, and I've picked out two that I'm aware of. Endometriosis UK. I think they're very, very good at advocacy. They organize webinars, events, symptoms checker, nurse support helpline. Also, they tell about endometriosis. There's something about endometriosis-friendly employer scheme, in which case, if you, as an employee, you have rights if you have been diagnosed with endometriosis, and they could help you in terms of if you're having to take time off work so that you don't lose out at the workplace. So they can advocate for you as well. So if you check their website, there's lots of good stuff in there. And also there's this one called Endometriosis Foundation. So you can check out this website. They're quite useful. So in summary, just to wrap, to bring everything together, we should know that endometriosis is a chronic condition affecting many women. I saw a stats to say about 1 in 10 women are affected. It could even be more, depending. And early diagnosis and a combination of treatment can help manage symptoms and improve quality of life. We should know that women with severe disease should be referred and managed at the endometriosis center. So these are centers of excellence. And I mentioned that even nowadays they use robotic surgery, which is also like a keyhole surgery, but advanced keyhole surgery to manage these cases with a good, very, very good outcome. I think I've come to the end. Thank you. And thank you for listening to me. Thank you.
Thank you very much, Dr. Ajayi. Now, I've got a few questions. Some of them are endometriosis questions. Some of them are just general women's health questions. Let me start with this one. Can a woman outgrow endometriosis without treatment as she grows older? Is it something that can be outgrown?
Okay, sorry. If I do want to answer that question, we take it in turns.
Okay. So I wouldn't necessarily say outgrown. So sometimes symptoms can be better. I mean, everybody is different, but that word outgrown, I wouldn't say so. If the tissue is present in different parts of the body, it will remain there, isn't it? Women can learn to manage the symptoms and then it becomes sort of normal for them, but that doesn't mean it's outgrown. However, as a woman gets into menopause, and the hormones are not being active, some women do see some relief of the endometriosis symptoms after menopause. But I wouldn't necessarily say it is outgrown as you grow older. Don't forget that painful periods doesn't have to be endometriosis. So sometimes you can have painful periods, which is not endometriosis. And especially when the girl just starts her periods, it can be a bit painful and heavy, and then that settles. That doesn't mean it's endometriosis, but endometriosis itself, I don't think it's something that we would outgrow, except when it's menopause and everything stops.
Yeah, exactly what I was what came in my mind. In terms of when you get to menopause, because there's no more estrogen feeding the endometriosis tissue, then naturally you expect the symptoms to be less. So, but yeah, that's the only way. That's the only way you can say maybe it's going to stop once after menopause. Yeah. Thank you, Fed. That was yeah. Thank you.
Thank you very much. Now, Dr. Ajayi, when you were doing your presentation, you did mention that, part of what could be used for endometriosis is this birth control pill. So what would you advise a teenager, that has endometriosis? Because I don't think it's an age-related thing. What would you advise a teenager that obviously is not sexually active? Would you advise them to go on the birth control pill? What's your advice going to be on this?
Okay, thank you. That's a very important question. So for teenagers, for our young patients, so normally what we recommend is when we listen to the history, and then maybe we've done a scan or everything looks as if it's most likely endometriosis. We'd like to start them on the hormonal medication, which is the birth control tablets you're talking about, Pastella. With the aim of controlling the symptoms. So we are not asking them to do anything. We're not putting anything in their head in terms of if they are not sexually active. We're not encouraging them to be involved in that area of that side of things, but we're using it essentially to manage their symptoms. So this can be very sensitive in terms of, some families with strong Christian culture, in that sense that, oh, why are you giving my daughter birth control pills? But the emphasis would be that this is a medication that will help them, and we are not, as medical personnel, we're not saying that they should do anything, but we're just using this to help to control their symptoms. So I don't know if first perspective from the GP point of view.
Yeah, you're absolutely spot on, sir. And just like you said, some families or cultural background or religious background might make people a bit shy away from hormonal treatment. But just like you said, it's the why are you using it? You're using it to control your symptoms, not as a contraception. That hormonal treatment can work for endometriosis and can also be a contraception, but you're using it for a symptom endometriosis, not for contraception. When you become sexually active, then it can serve the role for the two of them. But the fact that you're using it for endometriosis does not mean that you need it for contraception. So it's just understanding and explaining that to people to understand that you're using it for your symptom control.
Thank you very much. Now I've got another